Welcome back to the Lipoedema podcast. We are your host, Shell.
And today we are joined by a very special guest, Plastic and Reconstructive Surgeon, Beryl Tan. Dr. Beryl Tan, thank you so much for joining us today. Welcome.
Hello. Hi.
It's such a privilege to have you on.
Oh, finally.
Yeah. We met you for the first time at the Lipoedema Australia conference, and it was so nice to connect. I've been itching to get you on since the start of the Lipoedema podcast. And now you're here, and we've got some questions to ask you.
Great. I'll try my best to answer.
Fantastic. You're the right woman for the job, I think. We're curious, how did you come to learn of Lipoedema, and when was that?
Not surprising. I didn't learn about it in medical school. I did not really learn about it in my training. I'm talking about 15 years of training. It's only when I went to Germany. So once we finished our subspecialty training, so in my case, obviously, it's plastic and reconstructive surgery. Many of us go overseas to learn a bit more about certain specialties. So I went to Germany and I spent some time with this plastic surgeon called Dr. Dirk Richter. At that time, he was based just outside of Cologne. I can't pronounce it. Oh, Westling, sorry. I can't pronounce the hospital's name. And they do a lot of body contouring. He does a lot of safe around eyelid surgery as well. But there's a lot of body contouring. So that would involve the massive weight loss patient and lipedema patients. And that was essentially my first exposure to that kind of cases, to lipedema as well.
And so did that set you on the path of being interested in lipedema, or how did you then come to be one of the more prominent surgeons that help our community? How did that
look? To be honest, sometimes I wonder as well. Look, I didn't go there just specific for lipedema. So it's because I do a lot of body contouring. In fact, I started out when I came out as a specialist. There was like 20. So I finished 2016, I think. Yeah, I did more sort of body contouring. And before I have my own practice, I work with a couple of other plastic surgeons based out in Donvale. So you might have heard of the Plastics and Reconstructive Surgery Melbourne. So Dr. Raminda Dhillon, you got Dr. Snehal Shah, and Dr. Vani Prasad. So as you might know, because I think there's a lot of lymphedema, lipedema group, those familiar names with some crossover, right? Dr. Vani Prasad and Dr. Dhillon, they do a lot of lymphedema and they don't like liposuctions.
Interesting.
Then they got me involved. A liposuction is hard.
Yeah.
Okay.
You mean physical?
Because I do
physically hard.
Yeah. Liposuction, I do liposuction anyway, not just for weight loss patients, as part of body contouring. So I said, because since I've had the exposure, I've had the experience, and I've learned that before. So yes. So I started doing, I think maybe 2018. And I think from there, I suppose it's because of the, I don't know, Facebook group or something, the word spread it out. Yeah. And my approach is a bit different from another plastic surgeon in Melbourne. And also quite different from the other two surgeons in Sydney. If you speak to 10 plastic surgeons, it's the same when I went to the Lipoedema Congress, the World Lipoedema Congress in Germany last year. We sat there in the audience, and like different German doctors come on stage and they're talking about how they do things. Everyone does different things. Yeah. But it is, you know what, I believe all of us are like still on a learning curve. Not just about the scientific side, as there are more research now about lipedema, which is great. But even treatment-wise, a lot of us have learned a lot over the years. So I'm still learning, basically, and it's good to have some experience. So I learn a lot from patients as well. A lot.
Right.
And then and often one way is not. There's no one best way, or to put it simply, there's no one nail for every patient. Yeah.
Sure.
Yeah.
Okay. So you mentioned before that the surgeons that you do know of, they all have different techniques and ways of doing things.
Yeah.
So let's talk about your method. What do you use for lipedema extraction surgery, and why?
Okay. look, yeah, I'm a surgeon, so I like to talk about surgery. To put it simply, that I just put it in two groups, okay? So liposuction, one group, and the other group is liposuction with skin excision, okay? So one is to reduce the fat volume only, and you have some indirect effect on the skin, obviously, but it's the second group that you actually cut the skin at the same time. But you do liposuction first, okay? Because as you probably know, if you compare this to, I always explain to the patient that, look, if I'm only doing small step and I put my cannula in, I'm going in and out, and the way we do it is like we're trying to preserve. I am moving fat, but I'm trying to preserve as much of the stuff. So I like to tell people to imagine, okay, I've got this big mansion with lots of rooms and lots of bad tenants of fat. Okay. But there are also some good tenants too.
Yeah.
Okay. I want to get rid of all these bad tenants as much as I can, but I don't want to break down all the wall because a lot of the walls have the plumbing works, have the electricity, the cables and all that. And I need that to keep the skin alive, right? There's the good thing about liposuction is you can keep a lot of this thing depending on where you are liposucking. So, there is aggressive liposuction. There is not as aggressive, meaning you probably heard of the 2 layers of fat under the skin, the superficial, and the deeper fat. So I always say that the money is the deeper fat. So that's my target. But when it comes to the superficial fat, which is the fat layer right under our skin that keep our skin like bouncy, that is important because there's a lot of lymphatics there and there's a lot of blood vessels there. So when I liposuck that area, which is usually like after the major liposuction, I use a smaller cannula to liposuction that area, more like a fine tuning to even things out. But I don't go crazy over it because again, unless I know that, I'm going to cut the skin out, and I go all out. Yeah. Okay. So liposuction, that's one of them. Yes. There you go.
We have a visitor.
Yeah. So try to. Sorry. The other method, say for instance, if I know, as older patient, people who have massive weight loss, older patient, where I know the skin has stretched past its maximum ability to bounce back. So usually standard patients above 40, 45, when your skin is not as thick anymore, sometimes I will say, look, I cannot avoid cutting. Right. Okay. I can either stage it or do it there and then. Yeah. Does it make sense? I'm a strong believer in staging. So again, it might be confusing. So you have these two groups. So staging means I do this first before I cut.
Liposuction in one surgery or many surgeries, and then skin revision in separate surgeries. Yeah.
Yeah. Especially patients between 40 to 50, when because I see patients in their early 40s and their skin is actually not bad. But the reality is the more I liposuck, the looser the skin's going to be. It is the same as patients with massive weight loss. Now, bearing in mind, and you have to be clear, liposuction is not a weight loss surgery, okay? Yes, I'm removing a lot of fat. Fat is light, okay? But the effect is like someone who's lost a lot of weight. And as you probably know, someone who's lost a lot of weight, the problem often is the skin. Yeah. Or the skin fold because it doesn't bounce back anymore. So patients around 40 to 50 usually, if they have, I assume everyone's familiar with the stages with lipedema.
Yeah, somewhat. We do talk about it on the podcast at various stages. Yeah.
Okay, good. Just to make sure everyone is familiar with it, you have stage 1, where stage 1 is always tricky because stage 1 means the subcutaneous fat, meaning the fat under the skin is thickened. Okay, but the skin is okay. So often can be quite hard to diagnose, and often as lipedema patients have symptoms. So they can have the symptoms, but then if you look at it, it's like, it's actually not that bad. So that's often a stage 1. Then you have the stage 2, where then the skin starts to become a bit more uneven, and then you start to get the nodules. So after that, stage 3 and 4, it gets harder. Okay, the fat becomes bigger. It's like lobular. Okay, instead of nodules, it become lobular. Remember the house I was telling you about, the tenants? And the cells, the walls become thickened, so it becomes more fibro. And those fat is actually harder to get rid of as well. And the worst case scenario is the stage 4, when the lobules of fat has become so big that it's starting to compress on your lymphatics. And that's why people then get the lymphedema. Okay. So if someone comes to me stage 1 and 2, often if I have to decide, the fat is not so bad, the skin is not too bad, but might be on a thinner side. Again, in this case, it really depends on how the person aged as well, whether there's a history of excessive sun exposure, whether the patient has been smoking. All those are bad aging factors. So anyway, but in the 40s, 50s, I'll say, look, let's liposuct first. Don't give you big scar if you're stage 1, 2, sort of early 3. Whereas if you come to a 3 and 4, 4 is pretty much like most of the time you're going to have to cut because it's that bad. So 2 and early 3, there's a chance that you can say, okay, might be able to get away with just liposuction. And then remember I said there's a sort of like a secondary or indirect effect to the skin. So if I suck out as much as possible and let the skin have the opportunity to shrink back down, because again, it depends on which area as well. So the leg, it contract better. The thighs, again, depend on which part of thighs. I have to look at the severity. I need to look at the patient factor and how much fat I'm going to take out. So the more fat I take out, the more loose skin it's going to be. But some people, after 1 year, they might have enough shrinkage or contraction of the skin to say, look, I don't want the scar. Because whenever we cut, the second group, we cut, you're going to have an external scar. This is unavoidable. Everyone's tolerance for scars is different. That's why I say there's no one nail for everyone. Look, it sounds simple, liposuction will cut the skin. But then how I stage it, where I focus on, it really depends on the patient. And briefly, I just want to also mention that patient usually 30 and above, 30 to 50, I also introduce another treatment modality, which is called Renuvian. Basically, Renuvian, I'm not sure if you've heard of it. It's a device. It's a heat-generating device. Look, firstly, I want to explain. Why heat? Because we know that when heat touch collagen, so, the walls is made of collagen in our fat. So if I use heat to touch near the skin, the walls that support the skin, the roof is our skin, it shrinks.
Wow.
So the hotter it contracts. And in the case of Renuvian, basically it's a technology that uses radio frequency energy, or commonly known as RF. You can get RF treatment in dermatology clinic or beauty med spa or something, where they use it on the skin. Now, if you apply on the skin, you can't go too hot because you can burn the skin. But in case of Renuvian, I'm going under after liposuction. So I'm basically going in with the handpiece, and the handpiece is often quite smaller than the liposuction cannula. I go in, and the handpiece emits the radio frequency energy and helium gas, and when they touch at the tip of the handpiece, but it's like a heat.
Wow.
Yeah. So it generates heat. And so basically what I'm doing is that once I've done liposuction until I'm happy, I use the Renuvian and I treat each area by area, 6 passes each area. Depending on which area as well and the thickness of the skin, sometimes I can actually use up to 80 degrees of heat. Now, if I put 80 degrees on your skin, I'm going to burn you, okay? But if I do it with the liposuction, which is done wet, remember, we put fluid, because it's wet, by the time the heat dissipates out to the skin, it's less than 40 degrees. The risk of burn goes down. I find that for some people, especially if you're less than 40, the Renuvian, it can, I'm talking about less than 40 and also maybe more like stage 2, not stage 3. They can have significant contraction that usually I tell patient it's about 20-25% contraction that they may not need skin excision at a later date.
And it's a wait and see.
Yeah.
So you've done the liposuction, you do the
Yeah.
Renuvion on qualified patients, and then you wait and see a year or
Yes.
so down the track, the skin hasn't retracted, then you might do an excision.
Yes.
Yeah, great.
Yeah. And the heat with the Renuvion also promotes new collagen formation. So that effect goes up to 9 months.
Love that.
Yeah.
The opportunity
Yeah.
for new
And can I
collagen.
just specify? Can I specify that you're going in the same incision point as the liposuction cannula?
That's
So
right.
you go in with the liposuction, then in with Renuvion.
Yeah.
Okay.
Yeah, for people who are not familiar with liposuction, when people ask me, oh, so which liposuction you do? So basically, to let you know the types, there are several types. So the conventional one is called suction-assisted liposuction or lipolysis. So that's SAL. Then you have power-assisted liposuction, which is what I do. So basically what that means is there are different types. So basically the ones I do use is called micro air. It vibrates, some oscillate. Essentially, we introduce all this different additional power so that the surgeon, the surgeon doesn't have to work too hard and push in. As it is, we go in and out. But the power helps to break down the fat before we suck it up. And then you have the water jet. So with the water jet, or I think the brand is called Body Jet, it's spray water. So imagine when you use a hose to spray down the driveway, it's like that. You spray as you go in and suck. And then you have the ultrasonic one. The brand is called Baser. That is a very powerful tool. So look, each one will have their pros and cons, but the more powerful it is, the higher risk of getting deformity or contour deformity. And there's also laser. For me, I use mainly the power-assisted liposuction. Now, with this, all these liposuction is all done wet.
Right.
So, so wet means, again, wet can mean many things. Okay. But to put it simply, the popular technique, or the ones I use, I do 1-to-1. So basically, if I look at this person's leg, for instance, I say, oh, I think I can take about 1 liter out. So I put about 1 liter of the fluid. So the fluid has local anesthetic and also adrenaline. Now, the adrenaline is important because the adrenaline is the one that causes the vessels to shrink, to contract, so that when I do the liposuction, you don't bleed too much. Okay. Whereas if you do dry liposuction, meaning no fluid, the risk of bleeding is very high, excessive bleeding. Yeah. Most of us do wet liposuction. Some people do. So that 1-to-1 we call super wet. And then you can have tumescent, which is like 4-to-1. So you put a lot more fluid and suck one. With the body jet or water jet, look, I've seen it used in Germany. I haven't used it, but I'm quite keen to learn. So I'm actually going to learn to use it as well. And I can see the pros and cons of it in the sense that with the technique I use, I put the fluid in, I wait for adrenaline to work. Whereas the water jet is you spray and suck at the same time. So in terms of time saving, there might be advantage of that. And watch that space. But look, how much local anesthetic we put in is really determined by your weight, your lean weight. So often we can't put too much, to be honest. We have to think about not giving too much that may cause a local anesthetic toxicity, particularly to the heart. You've heard of people dying from local anesthetic toxicity. It's because they give too much. That's why I do it in theater and with the anesthetist. And people also ask me, do you do it under twilight? Twilight means you just have sedation, and I do it. I prefer to do it under general because I can do a much better job because sorry about that. You don't have to cause too much pain because I have heard of so many horror stories of other patients being on twilight or sedation and you're still aware of what's going on and you're in agony. So I rather topic. And so I apologize
Totally
about that.
Fine. She wants her time on the podcast.
Yeah. Anyway, so I do it in theater, and especially if we are aiming to liposuct more than 5 liters. And the moment I cross the 5 liter mark, if I know that I'm going to cross the 5 liter mark, I'll put a catheter in as well, because 5 liters and above, the amount of fluid put in and we suck out, it can affect the total amount of fluid in your body. So we need to know how much your body is, how much urine your body is making. And if your body is not making enough, then the anesthetist can replace it with the intravenous fluid as well. So the input and output, and I tend to keep it overnight until the morning and then take it out then. And or anything below 5 liters, sometimes we just put at the end, just put it in and out catheter as well.
Because
and I do keep patients in overnight.
Sure.
Yeah.
Because we get a lot of the community asking about literage and time on table and whether you have limitations. But can you just clarify what the limitations are? Is it the fact that you have a limitation of how much of the anesthetic can be pumped in, and that's when you call it finished?
Look, no, the limitation has a lot to do with the safety of the patient. Yes, it's a combination of anesthetics. And don't forget, as we know, if you're on prolonged anesthetic, that can affect your brain as well. And during that time, we also, it's not just the fluid input output. We also look at that. I also make sure that the patient doesn't go too cold. So there are things we need to do to basically for your safety, for the patient's safety. And we know that I don't believe there is a number out there to say that you have to have the anesthetic less than 5 hours. But look, I do a lot of big reconstruction surgery as well, like breast reconstruction. Sometimes that can go for 8, 10, 12 hours. But for something like liposuction, I don't really want to go past 6 hours. It's the same as same principle as management of massive weight loss patient. Massive weight loss patient, there's a lot of skin cutting, some liposuction as well. And it's about keeping patient warm. It's about being safe, really. And I attend often with massive weight loss patient, they'll say, can you do this and this? There's so many areas. And I always say, look, no, I only limit that certain amount of time, about 6 hours, and I can do this. And I'll have to do the other part later.
Which is where the staging comes in. Yeah.
Yes, that's right. That's right.
Yeah. There's also a physical limit to how long you can be operating for. That's right. Yeah, so you've got to, yes.
I usually try to have massage a day. I do have assistant. Sometimes she helps a bit and she does the massage. A patient called her my main squeeze. She does the massage and look, I use both hands. I swap from my wrist to my elbow to my shoulder. So I change position. I sit sometimes. So you're right. Sometimes I got the tennis elbow from that. I go to gym a lot as well. I'm pretty strong now. So you learn how to adapt and make sure I have off days. And I do limit how many cases I do as well. I don't have huge numbers because I'm also thinking about my longevity. So the longer I want to do this, I have to make sure that I can last that long.
I can imagine that 6 hours in a surgery doing what you do could be so exhausting. And it'd be like going to a gym session for fun the next day with your muscles.
Yeah. And not to forget, it's not covered by Medicare liposuction only. I try my best to limit the hours, and it is a hard one, I can say, because I'm trying to get as much out as possible, but then you are also limited by the time. And usually when you send quote of surgery to patients, I try to take into account, okay, how much I'm going to take out, what areas I'm going to focus on. So as a stage 1, I like to focus on the area that is the most problematic, the most symptomatic, in most pain, because you want to get where it hurts most, so that if I do have to come back later, sometimes I have patients who say I take 6 liters out of the areas, usually around knees, around joints, and then they become more active because it's like the pain is not there anymore. They can do more and they've lost so much weight. Yeah. So I like to, usually especially the second consult, I like to see patients twice at least. The second consult, I stand them in front of the mirror and say, look, okay, let's make sure that we're on the same page here. Where would you like me to focus? If you have the limited time, where would you like me to focus first? And yes, and not forget getting that if the back, some people, back is a problem. So I sometimes have to treat the back in a face down position, or we call it a prone position, or I call it a Superman position. It's literally like a Superman. And for that, it takes about 6 people to transfer you from bed to bed and to protect your neck, protect your head, and then to put you back again on your back. It adds time. And then we had to do the whole prepping and draping again. So there's actually a lot of things that's going on, not just a simple, my pie is only one small part. There's actually so many things going on. Yeah.
Yeah.
Mm.
I love that. And that was something else I just want to touch on, because we had the privilege of listening to you speak at the Lipoedema conference, and that was just amazing. And one of the most beautiful things that you said was how this is a multidisciplinary thing, that last point, that all of these things have to be in place before we get to the surgery. Like, you're the goalie in the soccer game. All these people are going to touch the ball before it gets to you.
Yeah.
So how do we determine if a patient is surgery ready?
Look, when patients see me, I like to use this PowerPoint presentation that I did several years ago. Actually, I was at Edema Institute in Melbourne, and I gave a talk. There was a special session on lipedema, and so I gave a talk about lipedema to lymphedema therapists and patients. So I like to use the slide, and one of the slides shows that I go through what lipedema is and what the difference between lipedema, lymphedema, why is obesity relevant, why is a vein disease relevant. Anyway, so if someone has a vein problem like a varicose vein, that has to be treated first, okay? Because big veins, if I hit it, can bleed a lot. So anyway, to be surgery ready, it's just like a management of lipedema. You have to think of different aspects of the patient. When it comes to management or treatment of lipedema, you have to think about the patient, okay? So I put that as number 1. So that is the top thing is self-care, okay? So self-care involves a lot of self-discipline, okay? And self-care involves a different aspect of yourself. So you have the physical side, yeah, you have the mental side, okay, and not forgetting the social side as well. So when it comes to the physical side, it's not just about other medical issues, and often young patients, they don't have other medical issues. So, but I need to make sure that they lead a good lifestyle. So as the lifestyle is so important in treatment of lipedema. And what I mean is, number 1 is diet. We know all about diet and exercise. I'll tell the patient about, look, the diet part. It's the way I put it sounds simple, but the reality is not that easy for many people. So diet, I can say, go and eat Mediterranean diet, low carb. And often some people will go, oh, what does that mean? If it's too hard, if it's too overwhelming, there's always help at hand. So always remember there are people out there to help. So you can see a nutritionist or a dietitian. Okay. So I will say, look, evidence shows ketogenic diet has been shown that it really helps lipedema patients. But not everyone can do ketogenic diet, because it requires a lot of self-discipline, a lot of planning. Okay. If you can, by all means, go for it. But if you can't, then you have to think about plan B, plan C. There are other options. I usually say, look, aim for the Mediterranean diet, colorful vegetable, colorful fruits. Fruits, you have to have a limit as well, because there's a lot of fructose. But you aim for colorful diet and low carb. So the easiest way is, say, the plate. So if you are used to half your plate full of pasta or bread, and then quarter of veggie, quarter of protein, no. So you're aiming for vegetables, half your plate, quarter protein, quarter carb. Okay. So low carb, and if you can, anti-inflammatory as well. Now, anti-inflammatory has many meanings. Okay. Often, look, this field is becoming bigger and bigger, because we all now know about the gut microbiome and how it affects the inflammation system in your body. And I'm no expert, so it's good to get someone to talk about that as well, about how everyone's different. Some people might be sensitive to wheat, and the one diet, which is again quite a hard one, it's called AIP diet. It's an autoimmune protocol. I like it in the sense that you start eliminating some groups of food, And then you reintroduce it and basically try to track how your body feels. And you can find out then that, oh, my body doesn't take the bread very well, or the wheat, or the gluten, or the milk. So that's a good one. But often it can be so confusing. It's good to get help. So diet, number one. Then exercise. Now, exercise can be quite hard for many lipedema patients, especially stage 3 and 4. It's because of the pain. But having said that, I have a lot of patients who are so active. So they do a lot of exercises, and the pain is actually not bad. And I believe, as we know, exercise reduce the adipokines. So adipokines are cytokines produced by the fat, and they are pro-inflammatory. That's why people are sore. The pain is a hallmark of inflammation. Okay, if they can do exercise, they can actually reduce the symptoms as well. So they can just have, say, an ache or a heaviness rather than severe pain. Yeah, and some patients, if they, no matter what they do with the diet, I have a patient with she's so strict with the diet, she is so diligent with the exercise, but she just cannot shift the weight and the pain. So in that case, I lower down my threshold and I do the surgery earlier. As long as I see a commitment from a patient, she's ready. She's got good nutrition. She's got good exercises. She's got a very good therapist that will have been helping her pre-op and post-surgery. So I'm talking about all the physical side. And then mentally, she's got help as well. She's got a supportive husband, supportive family. And so all this links together. It's not just, I say self, that's number one. But then under that self, there's actually many people who can help you, because sometimes it's just too overwhelming. You have to deal with the pain and then all these different things. So it's not easy, but get help. And if you can have that, make that lifestyle change that become a routine for you, because ultimately no matter what I do as a surgeon, you want it to be worth your while. Okay. Studies have shown that it's effective in symptoms management, in improving cosmetic appearance as well. But it's not a cure, remember, it's not a cure. We're trying to relieve your symptoms. We're trying to help you by reducing the amount of fat. And then after that, you have to maintain it by what I said to you just now. Because if not, we know that the fat can come back. Okay, I cannot remove all the fat because we do need fat. So the fat has adipose stem cells as well. So if you're not careful, unfortunately, they can come back. In fact, studies have shown that they sometimes come back, and they come back as belly fat. Then that I can't remove as with liposuction. Having said that, we as far as I know, although belly fat is a white fat, just like the fat under the skin, but as far as I know, I don't think belly fat is involved in lipedema. I don't think so. But belly fat is the bad one. Belly that men get sometimes. There's a lot of fat.
Definitely one of those health indicators, or poor health indicators.
Yes.
Yeah.
Yes.
That's the visceral fat, isn't it? So around your organs and stuff as well. Yeah. Yeah.
I liked, I think it was Lucy Mackin. She talked about what to bring to hospital. I think that's a good one. I also want to make sure that patient has informed their therapist as well, and to make sure that beforehand, like some patients, they do DIY, because therapist to them is too expensive. So they buy their own garment, they do their own massage. But I always say, look, you have to touch base with someone, because you have to make sure that these people, especially the good ones, are really hard to get into. So you have to book beforehand that after surgery, you're going to have your MLD minimum once a week for 6 weeks, minimum. Okay. If you have those pneumatic compression pump at home, you can just go once a week. So the pneumatic compression pump is great. If you can do it at least once, preferably 2 or 3 times, morning, afternoon, night, just to drain the fluid. And then the MLD by the therapist can focus on some areas that is a bit harder for the pump to focus on. That is so important. And some people, especially if I walk around the ankle, you're gonna struggle to walk. You might have to hire a walking frame to walk. People often say that, oh my gosh, it feels like I've had intensive calf exercises and now it is so painful, and that can go on for a week or 2. You have to make sure that things are in place at home as well. And people can help you with putting the driving. You can't drive for at least a week. housework, food, who's going to take care of the kids, who's going to help you shower, who's going to help you with the garments. So all these things, you have to think about all that. And I have a couple of patients who didn't really set things up properly and they really struggle. And as I tell every patient, look, I want you to rest. I want you to walk as well, because I don't want you to get deep vein thrombosis. If there's so many things we can talk more about after surgery care, but there's so many things you have to think about and plan ahead. It's better to plan ahead so that you don't get surprises and you know what to expect. And you have the, someone on speed dial to come and help you as well. Yeah.
Yeah. Yeah. It's really involved, isn't it? And like you just said, then you've got post-care, like after surgery care as well. But then I guess if we get ourselves in that good condition for surgery, we just continue that afterwards.
Yes.
And really, keep caring for ourselves like this. We're getting rid of the tissue, but not the condition. So we still have to continue to do those conservative measures, to eat properly, exercise, wear compression, get MLD. Like, that doesn't stop once you've had surgery.
And it's important. I spend usually about an hour a patient in the first consult, and because if you plan the aftercare, if you plan it, you do the right thing, then you get better results. And many people don't understand. I think it's very important to understand about our healing process, human being, about the 3 phases of healing. To put it, I try to put it simply. So the first phase is our body trying to protect itself. So we call it acute inflammation. Acute inflammation is when the body sends signals, the cytokines, send signal for the brain, tells the body, okay, it's time to send more blood to the area of injury because you need to protect yourself. So white blood cells go in, fight the germs if there's any invasion. The platelets goes in to stop any bleeding. Okay. Inflammation goes up, peak around day 3. Okay. That's why after the first day, patients swell because there's more blood directed to the area. So you imagine, I tell patients, imagine your fat layer is like a foam, say a sponge, okay, a sponge. So that nice sponge, the yellow sponge, I've been making a lot of holes in it. I'm taking a lot of the yellow sponge out, okay? So what happens is that sponge goes, because I've emptied it out, yeah? But within a day or 2, it's going to go back because all those holes I make is going to be filled with fluid because of inflammation. Okay. Inflammation starts going out down the second week, and often it can go down. It might take 2 to 3 weeks to go right down more. But for liposuction, it can be even about 4 to 6 weeks. Now, when the sponge is all filled with fluid, I don't want it to be there because I want the sponge to be squeezed, the fluid goes out so that then that's what the pump and the massage is for. Try to drain as much of fluid out of the sponge. Then it's flat again, and then wear compression. So that when second phase of healing starts, which is usually the end of second week. Now, the second phase of healing is what we call scar proliferation. The army goes away, the builder comes in.
Right now.
Okay. That is when your body starts to make scar. Okay. Now, the scar or the cement, okay, is a slow process of putting cement, okay? The body takes about 6 months to 12 months, or some people even longer. You can tell when you cut yourself, the scar becomes quite red and bulgy sometimes. That is because you're still healing, okay? It's only the third phase of healing when the scar mature, and that only happens after 6 months, sometimes after a year. Then the scar mature and settle down, become flat and pale, okay? That whole process is 1 year to sometimes even 1.5 years, okay? See, when your body starts to make scar, okay, so after 2 weeks, so the fluid goes, then the scar comes in. I want the scar to be made with the sponge compressed down so that all the fat is compressed down, the wall, everything is compressed down, and then the skin has an opportunity to contract as well. Then you get a better tightening too. Whereas if you still have a lot of fluid, then it's just big. It becomes like a pocket of fluid there. And often, some patients will find that, oh, I've got this pocket of fluid, and that's why MLD is important. Someone physically trying to drain that some pocket. You try to drain as much as possible and then put the garment on. So you don't want it to be accumulate again, because that is if you don't drain it properly, you're just going to end up with all this little lump. And that's for 6 weeks, especially because it takes that long for the scar to be a bit more stable. Yeah. Make sense?
Oh, absolutely. And Beryl, I love your analogies.
Yeah.
Yep.
How how good is that, having that visual in our heads of how our bodies are working?
I think it's important for patients to understand, because then you understand, okay, what to expect, this is not right. Then you know, okay, it's time to ask, why is this not right? It's very important to understand why we do this, what can go wrong, what to look out for. If something go wrong, can we fix it, or do we wait? All this kind of stuff. And there's a reason on why we do this and why we do that. And all these comes with this years of treating different patients. And I try to be as thorough as I can, but often the first consultation is information overload. That's why I do need to see patients the second time. They have a chance to read through the information and to ask me questions. And then I can go through, stand them in front of the mirror and go through the areas that they want me to treat first. Yeah. Because sometimes, often because you're going to pay a lot, people will say, can you sub as much out as possible? So as much out as possible. But and to be honest, it's better to focus on one area, because often if I do the lower limb and I do the arms, and it's really hard to get up and walk around with everything sore, and can hardly even hold the frame because your arm is too sore.
Yeah.
Yes.
Yeah, true. I couldn't imagine having my legs and arms done at the same time. No, thank you.
Some people do ask for that.
Thanks.
Yeah.
Let's try and get it all done. Beryl, thank you so much. We have come to our last question. Where can the Lipoedema community find you?
On my website. Look, my website is pretty simple. I set it up just for, you want to find out more about me, it's just to have a presence. Physically, I am based in Cabrini Hospital in Brighton, in Melbourne. I also consult out of Donville Clinic. That's with the other group I was telling you about, because we do often work together. So some patients who especially with lymphedema sometimes get surgery done by Dr. Dillon and Dr. Prasad. So those are my two areas where I consult. I operate with liposuction surgery. I operate mainly out of Epworth Freemason in East Melbourne, because that's also where I get really good support there from the nurses, the ward staff. There are plenty of machines there, and my Renewa machine is there as well. So that's the area. And and I've got very good staff in Brighton, so they're quite responsive to email as well if there's anything people want to ask.
And do you do phone consults? Phone or in person?
I do. I need to do at least one in-person consult. So as you probably know, there are several new guidelines that came up since July last year. It's set by APRA. It's basically to protect patients from cosmetic cowboys. Anyway, one of the criteria now, because there's no Medicare number, is deemed as a cosmetic surgery. So I have to follow that rule. So one of the rules is that I have to consult you twice. So one can be in person, one can be over the phone or over Zoom. But I do like to see you at least once. And like I say, I do take pre-op photos, and I like to stand you in front of the mirror to explain things and all that. And the other thing that you might get from us, I usually get patients to fill in a pre-consultation questionnaire as well, just to better understand why you want to see me, how I can help you. And also now we have to add another questionnaire that is basically what we call a cosmetic surgery psychological questionnaire. It's for everyone, okay? Not that we think that you're mad, but basically we need to make sure, we just need to watch out for patients with body dysmorphic disorder, because often they need more help from a psychiatrist or a psychologist before they come and see us. So I need to have that screening tool as well. Yeah, so those are the two main ones. Yeah.
Oh, fabulous. Thank you, Beryl. And anyone who wasn't watching and who was listening, they were Beryl's cats who were meowing earlier. They came for a visit while we were recording, and they were very cute.
You've given us such a wealth of information, so many things to think about in this episode. So thank you so much for your time.
Yes. So I do want to make sure, look, there are many plastic surgeons out there who do liposuction as well. Just make sure that they are trained and they are qualified to do, they understand about surgery, and they actually spend the time to explain to you what is done, how to prepare, and what to do afterwards as well, the aftercare. I think that it's very important. And I think, and you ultimately, you want to be safe as well. Yeah.
Yeah.
Mm.
Yeah. Thank you very much, Beryl.
Thank you. We hope to have you on again one day.
All right. So, the interesting. You can come up with I'll try to find more analogies to think about.
Yes. Thank you, Beryl.
Okay.
Bye.
Bye.